Distinguished speaker is Dr. Pramila Kalra, Professor and Consultant Endocrinologist at Ramaya Medical College and Hospital, Bangalore. Dr. Kalra completed her MBBS and MD from KGMU Lucknow and DM in Endocrinology from SGPGI Lucknow. She has received several national recognitions, including the A.V. Gandhi Award for Excellence in Endocrinology. She will speak on stratifying CKM risk with Life's Essential 8 and other composite scores in routine diabetes clinics. Please welcome Dr. Pramila Kalra.
Thanks. Thanks for the kind introduction. Am I audible? Hello, am I audible?
Yes, ma'am. You are audible.
Okay. Okay. So I'll just be sharing my slides. 1 second. I hope slides are visible. Slides
Yes,
are
ma'am.
visible?
Yes, ma'am.
Yeah. So thanks, Dr. Ashutosh and Dr. Pallavi for inviting me for this talk. And thanks for agreeing to do it online because there were some travel constraints at the moment for me. So I'll be talking about stratifying CKM risk with Life's Essential 8 and other composite scores in routine diabetes clinics. So we know that when we talk about diabetes management, it's in a busy OPD, it's sometimes very difficult to decide that what are the basic things we should do or we should do in a patient or assess in a patient to assess the cardiac, the kidney, the metabolic risk score. And many a time we end up not calculating their risk, and as a result of which we see many patients coming to us with complications and they haven't been evaluated or the rightful things are not done for the patient. Now, what exactly is this CKM syndrome? We know that when we talk about diabetes, we say it is a cardiovascular kidney metabolic continuum. And we know that when we talk about this CKM syndrome, we know it integrates basically in a way overweight or obesity with type 2 diabetes, CKD, and atherosclerotic cardiovascular disease. And we say that this is all a vicious cycle and it is a continuum. So one propagates the other. Patient who has cardiovascular disease, patient who has obesity has a higher risk of getting other problems, also higher risk of dying. Similarly, a patient with type 2 diabetes has a higher risk of getting chronic kidney disease, atherosclerotic cardiovascular disease. So all these are actually interconnected. And we know that patients who have diabetes actually have a higher risk of getting cardiac and kidney issues. They have metabolic health issues. They have higher risk of getting a cardiovascular event, heart failure, hospitalization, and also the progression to the chronic kidney disease and end-stage renal disease. And if we recognize these patients on time and we recognize them early with proper scoring systems, we can actually get the risk scoring faster and we can actually decide which patient to investigate and which patient to treat more aggressively. Now, when we are talking about the staging or the stages of the AHA-CKM definition, we say that stage 0, they have no metabolic risk factors and they have optimal cardiovascular health. Stage 1 is the point when they come with excessive adiposity, dyslipidemia, or impaired fasting glucose. Stage 2 is when they get type 2 diabetes and CKD and their eGFR is at least less than 60, or albuminuria is present, or both, or hypertension with metabolic factors. And then we have the stage 3 where they have the subclinical atherosclerotic cardiovascular disease. They have a higher predicted CV risk or heart failure with preserved ejection fraction. In the context of the CKM factors being there or the risk factors being there. And the stage 4, we know that it is the established clinical ASCVD or heart failure. And along with that, they manifest with varied organ damages also. Now, why this risk stratification is important? Because we know that in a busy OPD, as I told, it's sometimes very difficult that we assess these parameters and we may not be doing it properly. So we know that if you have this type of scoring, it actually enables a serial risk assessment. So you calculate the risk today, you calculate the risk on follow-up, and you don't know what is happening to your patient. It is similar to like we do a FIB-4 score for our liver disease, and we know that this patient is at a higher risk of progression to fibrosis And when we do it serially at progressive visits, we know that this patient needs more aggressive intervention versus this patient who needs less aggressive intervention. Also, it helps us to understand that there is a multidisciplinary team which is available, and it's just not the endocrinologist or the diabetologist who is taking care. It's cardiologist, it's a nephrologist, it's an endocrinologist or a diabetologist or a physician who is also involved. And along with them, you're the nutritionist and other people, psychologists. These are all the people who are part of the team. So when we talk about the metabolic parameters which are required, we know that HbA1c, lipids, EGFR calculation and blood pressure is already done for most of the patients. And when we talk about these structured tools, actually this is better because these outperform the clinical intuition, because sometimes what happens, we say, oh, this patient is at a higher risk of cardiovascular disease. And when we calculate the risk scoring, they may not be. Or it's the other way around, we say that this patient may be at a low risk. But when we put the parameters of the patient in the risk scoring, we find out that they have very high risk. So this is how it is important that we have validated risk tools rather than a single risk tool or just an intuition that this patient may be at a higher risk or this patient may be at a low risk. Also, if we have these, actually it reduces the undertreatment of the high risk individuals. And as I said, over treatment of the low risk individuals is also reduced, and we actually treat as per the actual risk burden of the patient. So when we talk about this life essential aids, now this is basically a AHA updated construct for measuring and monitoring the cardiovascular health. And it gives a 0 to 100 cardiovascular health score. And it is based on like poor score of 0 to 49, intermediate score of 50 to 74, and ideal scoring obviously is 75 to 100. And the new parameters have been added in the life essential aid scoring, including the sleep, because we know that sleep is an important component of cardiovascular health. Now studies are there to show that lack of sleep itself can lead to high risk of cardiovascular disease, can lead to high risk of metabolic disease, can lead to uncontrolled diabetes, can lead to shorter life as well. So it's important that these type of risk scorings are done so that we can understand that how we can apply it to the different populations, how we can use it for our high risk, low risk population, and how we can apply it to our metabolic health problems with our patients, how we can apply it for our type 2 diabetes and pre-diabetes patients. Now, when we talk about the components, we know that there are 8 components. So it's the diet quality. They're trying to see the adherence to the healthy dietary pattern according to the DASH diet or the Mediterranean style, or as per whatever diet our patients are advised to follow. Physical activity, more than 150 minutes per week, at least, like we'd say 5 days a week, but at least it should be all days of the week. That's what we expect. Also, they count the patient's exposure to nicotine, including the second-hand exposure, that is the passive smoking, and also it takes care of the sleep health. So it's important that 7 to 9 hours per night sleep in adults who are excessive sleep duration, both it's taken as a negative marker. And BMI also. That is, we know that for our population, anything above 23 is counted as overweight. Anything above 25 is counted as obesity. And also the blood lipids, including the non-HDL, which is the primary lipid parameter. Blood pressure, to maintain the blood pressure below 120/80. And the HbA1c ideal, we know, is below 5.7 for normal. But for type 2, we know that at least less than 7. And for majority of type 2 who are younger, who have no major comorbidities, we target a scoring of less than 6.5. So this is how this wheel we can remember. This is the wheel they have put. So we can see all the parameters here, including the lipids, including the diet, including the exercise, including the blood glucose monitoring, the HbA1cs. Sleep is a very important factor. This we have to understand because they have added that specifically. And we know that blood pressure monitoring is also an important factor. Now, as I told you, a low score is counted as less than 50, intermediate is 50 to 79, and a good score is more than 80. But we say that ideal is 75 to 100. So we know that it is just an arithmetic mean which is taken for all these scorings. And this helps us to understand the person's risk of cardiovascular disease, heart failure, stroke, or CKD progression and all-cause mortality. And it is very important, like we say for HbA1c, that 1% reduction can reduce the cardiovascular disease and the microvascular complications by the particular percentage. Similarly, here, Each 10-point increment in LEH score is associated with 20% lower risk of cardiovascular events in a larger prospective cohort analysis. And we know that this could be a continuous risk indicator. So it's not that today we do it and we forget about it. We do it at every visit and we say how the scoring or the risk scoring of the patient is changing. Now we know that there are multiple cohort studies which have established these prognostic values of this LEH score across a spectrum of cardiovascular and renal endpoints. And we know that if the patient has higher scores, they have lower rates of coronary artery disease, stroke, heart failure, and all-cause mortality. Also, we know that if the scores are lower, it actually correlates with faster EGFR decline and albuminuria. So it is a very good score for the cardiac, kidney, and the metabolic risk continuum. And also, we know that this kidney-specific signal is mediated through the blood pressure, also through the glycemic status and the BMI as well. Also, the subclinical atherosclerosis, we know that it is also associated inversely with the coronary artery calcium. So higher the score, the lower is the coronary artery calcium or the arterial stiffness or the CIMT. But the lower the score, we have more propensity for the patient to have a higher CAC score, higher arterial stiffness, and higher CIMT. And we know that these markers predict the risk of MACE events and dying of a cardiovascular disease. Now, if we talk about diabetes, we know that if a patient has also a lower score and also has some of the other components, like if they have normal albuminuria, it is likely that they are in the CKM stage 1 to 2. If they have albuminuria or EGFR less than 60, they are in the CKM stage 2 to 3. If they have a poor score with subclinical ASCVD, they are in CKM stage 3. If they have a poor score with established CVD or heart failure, they are in the CKM stage 4. So this actually helps the doctor to understand the risk categorization of the patient, and especially in our busy OPD setups where many of the patients don't even do basic risk scorings. This can be one of the good effective ways to do it, and we can teach this to our diabetes educator, to our nurses who can see the values and actually try to put a scoring so that the patient walks into your OPD, and even if you're busy and if this score is available, you can actually decide how aggressively to treat your patients for the prevention of development of complications. Now we know that there are varied other scores which are being used. We know that there are ASCVD calculators, there are QRIS scores, score 2, which the European Society of Cardiology has told about to incorporate the HbA1c, EGFR, age of type 2 diabetes diagnosis, and albuminuria. Then we have advanced risk models and UKPDS risk engines, which have been derived from the RCT cohorts. And we know that they also estimate the coronary heart disease and the fatal coronary heart disease and stroke and fatal stroke. And we also know that these ASCVD risk calculators calculate the 10-year risk and are freely available. And they also use the blood pressure, the diabetes, and the smoking and the cholesterol HDL values of the patient. But we know that we know that these are the traditional risk scores. We know that these scores are also available. Most of them have been validated across major populations as well. But we also need to understand that the LEH score, which we are talking about, is an easy score to put in the OPD because we don't need to put into a calculator, because though we talk about these scores, we know that we should do these scores, but most of the times we don't use them in the routine practice. And this scoring of the 8 parameters, including the blood pressure, the glycemia, the patient's smoking status, and the sleep patterns and other things, actually is an easy way which can be even done by a nurse educator. And we can actually catch these patients early and follow them up. And we also know that many a times the calculation of the cardiovascular risk may not be very good for our population, because it may be underestimated in a great majority of our population, because most of these risk scoring engines have more of the Caucasian and the Western population, though some of them, like the UKPDS, actually includes our population. But we know that many of the South Asian population data validation with these scoring is much lesser. Now we talk about the emerging CKM specific composite scores. We know that integrated into the multiple other things like the patient's HbA1c, EGFR, subclinical ASCVD markers, that can help us to understand the overall risk categorization. We can also be we are also aware that some biomarkers we are using, like the HSCRP, the NT-proBNP, which can actually improve the risk stratification for heart failure and other CV death parameters. And we also know calcium scoring, the coronary calcium scoring, the cardiac MRI derived parameters, carotid ultrasound also are being added into these risk models to have a better understanding of the cardiometabolic risk of a patient. So we know this LEH score takes diet, activity of the patient, the nicotine, the sleep pattern, the BMI, the lipids, the blood pressure, and the HbA1c. And when we talk of CKM staging, we know 0 to 4 using these metabolic parameters of EGFR, ACR, and organ damage. And then we have the ASCVD risk, which we apply the risk scoring engines, which can also help us to understand practically the patient's risk. So we know that this can be a composite data which we can get in our clinic. So not that each is in silos, we can use all these together and actually can have a better risk prediction for our patients. So when we have a low CKM risk, we know that LEH score more than 75, good cardiovascular health. They come mostly into the CKM stage 0 to 1. Their 10-year ASCVD risk is less than 7.5 with normal EGFR at least of above 60. With normoalbuminuria, no target organ damage. We say lifestyle optimization and annual reassessment of these scorings is okay. But if you have a patient with intermediate CKM risk, with a LEH score of 50 to 75 with a moderate cardiovascular health, with a CKM stage 2, 10-year ASCVD risk of 7.5 to 20, with microalbuminuria or mildly reduced EGFR, we know that we need to think about adding SGLT2 and GLP-1s. If your patients have a very high CKM risk, with your LEH score less than 50, with a low cardiovascular health, with a CKM stage 3 to 4, with a 10-year ASCVD more than 20 or established ASCVD, or the CKD with EGFR less than 45 or macroalbuminuria, you need even more aggressive multifactorial treatment with a specialist co-management specifically indicated in this category of patients. So we know that if you have a patient risk scoring, you can just low risk patient, you can intensify the lifestyle optimization and the dietary counseling, see that the sleep hygiene is maintained, smoking cessation is most important, and you can do the ASCVD risk assessment every 1 to 2 years, and you follow the standard glycemic management and the blood pressure management guidelines. And we know that if they have a high risk, then you go with more aggressive management. You prefer definitely adding drugs like SGLT2 inhibitors and GLP-1 analogs, which can give the benefit of cardiovascular and renal protection to these patients. So this is how we can definitely work in our clinics with a data capture, with a scoring, which can be incorporated as a calculator. Now, many of the centers are using these calculators, which are directly there. So once you put in these patients' value, automatically it gives a reading or a value, and you can do the risk flagging and definitely the action and the follow-up after that. So we know that we have to also capture a few of the behavioral determinants as well, like including the diet and lifestyle, the nicotine exposure, that's the smoking cessation is important, and sleep health is very important. So we might have to also see for OSAs, because many of these overweight and obese type 2 may have OSA. And even we have to understand that lean type 2 can also have OSA. It's not necessary that the person has to be overweight or obese to have OSA. Even lean people can have OSA problems. Mental health integration is very important. We have to talk about depression and diabetes distress, because which can actually impair the sleep quality, can lead to more addictions, lack of exercise, and can actually impair the LEH matrix. So if you talk about the dynamic scoring, we know that we do the scoring of the patient, see the CKM staging, do a 10-year risk assessment, and then we follow these patients 3 to 6 months. Again, reassess their matrix. So the metrics, we see the blood pressure, HbA1c, we see the post-therapy intensification, we see the behavioral metric trajectories and the lifestyle counseling. After seeing all these metrics, like in the form of BP, HbA1c, and lipids, and then we do a reassessment again at 12 months for the LEH metrics, and we update the CKM staging based on whether the metrics have changed, whether there are any parameters which have become better, and accordingly we can reassess the patient and rescore the patient to moderate to high or low, high to moderate. And this can be used as a performance metric for the diabetes care quality audits also. Like if you're a patient who is having a higher CKM staging and has become better now, and the CKM staging has come down, or you have put all the things which were needed for that high CKM staging patient, actually it improves your diabetes care quality as well. And this can be used as one of the audit parameters as well. So what we can do is we can definitely, as we were hearing the AI talk as well. So we know that now AI is going to stay, and we all need to learn that. And we know that machine learning models also are very important, because AI-enabled EHR embedded calculators is what I was talking about. Now, many of the centers have started using these calculators where you automatically put in the patient's data and you get a graph, and you get to know that this patient needs more aggressive intervention. There's a flagging which happens. So even if the doctor has missed calculating, you will get a flag or a red mark that you have to do. And advanced imaging phenotyping, we know the calcium, the coronary artery, calcium scoring, the MRI-derived strain analysis, renal cortical volume. These are all important things which are adjunct inputs to the CKM models. Not that you necessarily have to do them, but you might do it in high-risk patients. And also we know that some of the important markers like the NT-proBNP can be used for these patients, which can actually help you to classify these patients correctly. So we know that CKM framework actually is a very good way to reframe your diabetes risk for your patients. And it is one of the unified evidence-based continuum, and it can be done on every visit. So the most important is the follow-up, because you can do it on one visit, but after your intervention, you have to see whether there's an improvement or a deterioration. Also, we know that Life Essential 8 is one of the actionable things which can be done in diabetes clinics. We know that scoring systems with the CKM staging and ASCVD scoring is a good way to make treatment decisions for your patient. Now, with these scoring systems which are online and which are simple to use and can be integrated with your practice, I think these can be feasible options in our routine practice. And we can put it in our routine practice, and we can use it for the benefit of the patients, because now we know we have drugs like SGLT2 inhibitors, GLP-1 analogs available, which can be used in these category of patients and should be offered. Not that we don't need to use SGLT2 in lower risk, but what I'm trying to say is this higher risk group should be offered SGLT2 and GLP-1s, and we should definitely think about using these scoring systems to help us understand which patients should not miss the opportunity to get the benefit of those medications. So I think with this I end, and we can take the questions.
Thank you, ma'am. Thank you for your nice deliberation. And I think the way diabetes care is moving, more and more risk scoring system are going to be play in stratify our diabetic patient, because it is very important to stratify them and whom to treat and whom to be treated aggressively, and deciding upon the treatment. So in your opinion, where you find this another scoring system, that is LE8, on top of the existing system which are already existing? So is it able to add more information, or it will be just another score like earlier ASCVD, QRIX 3 or thing? What is the basic difference you are
See, the actual thing is, so if you see the parameters which we are going to use in these LE8, these scoring systems are quite easy to do. So the thing is, when we talk about so many risk engines or risk scoring systems, or even ASCVD calculators, if you see and if you try to remember in the past 100 patients we saw in the OPD, actually how many patients did we actually do the scoring? So frankly, we are not actually putting it into our clinical practice, because many of these calculators are available. We have to put the things online. Now, these scoring systems can be like LE8 can be an add-on also. It can be used solo also. At least if we miss doing other things, even your nurse educator, you can put these 8 parameters, and she or he can actually point out and see that what are these parameters. You can explain them, teach them while they are taking the vitals of the patient. These can be easily put by them, so that when you see the patient in your busy OPD, you actually know that, yes, this is a patient whom I need to do other risk scoring as well, and this patient needs more intervention. The other thing is, now with most of the AI-enabled hospital softwares which are there, many of us are using those softwares where these scoring systems can be directly incorporated. So once you put the HbA1c, the blood pressure, the smoking history, the sleep pattern which you normally take in a OPD setup history, this will automatically go on to that scoring system, and you can actually get the online scoring, and you the patient gets flagged that this patient is a high risk and you might need to do more intervention. As I showed you that many a times intuitively we think that this patient may be having less risk, but when you do the scoring system, they turn out to be high risk. Or it's the other way around also. Sometimes we think of the high risk and they may not be so much in the high risk, but the other way around is less. It's more of the patients whom we miss, whom we think as low risk, but actually they turn out to be high risk. So I think it's an important thing that these can be an add-on as well. Even in solo, yes, a good scoring system can be used with the other risk calculator so that we get a composite thing for the patient and we decide on what best to do the management. But at least if we do this, we can at least catch the very high risk patients and not miss them offering the drugs like SGLT2, GLP-1s, and also even statins, high dose. Because many times we don't even see the risk scoring and we end up giving low dose or low intensity statins where they at least need moderate or high intensity statins.
Yeah, that is very important. So, hoping that in busy OPD and in Indian scenario where we are seeing a lot of patient and we have very limited resources, this new scoring system is going to help. Some of the dietitians are also here. Would you like to ask anything from Madam regarding the lifestyle risk scoring system, the diet being one of the very important part? And in this regard, anything specific regarding the diet we can, or anything else, Dr. Pramila, any Indian specification you want to add, and just a small concluding comment that these are the two things we want.
Yeah, so very important because I appreciate Dr. Ashutosh that he brings out all these important topics in his conference because not many a times we discuss these topics properly. So the most important thing is the diet. See, if you see in our country, the diet is quite low in protein. And if you see a basic vegetarian or even a non-vegetarian diet, so-called, it is not very good in protein intake. And fiber intake is also very less. And mostly it is predominantly carbs. So what we have to educate our patients is that the protein intake in the diet should be very good. And even in a vegetarian diet, we can tell them to take pulses, curd, and actually some amount of paneer, which can actually give them a good amount of protein, even in the natural dietary sources. And if their patient is a non-vegetarian, obviously something like egg white and those things can be offered accordingly to the dietary pattern of the patient. So one thing is we have to focus on protein intake. We have to focus on good fiber intake because the salad intake in our diet is very less. We don't educate our patients about the plate size. We don't tell them about the 9-inch plate size many a times, though we educate, but many times those things are missed in a busy OPD. Also, we also know that resistance training is very important in our country because we talk now more about GLP-1s, SGLT2. We know that sarcopenia is a big problem in our country and we need to talk about resistance training, TheraBand exercises to all our patients, even if we are giving them these drugs or not giving them. Because these are important factors, I think, which should be an add-on as a part of a diabetes consultation or as a part of the dietary lifestyle modification advice to our patients. And my take home would be that any of these risk scorings will help us at least to understand the high risk patients because we now, with more of SGLT2 and GLP-1 analogs available in our country, it's a good idea that we do the risk scoring because we can offer it to the patients who at least need it. Not that we don't offer to others, but the thing is at least the patients who need these molecules should be given the benefit. And doing these simple risk scorings should not be just at one point of time. It has to be a follow-up. So like we do a FIB-4 score. Now for MASL, we simply do a FIB-4. Now FIB-4, if you do once and you don't do it again in the follow-up, you will not know if the patient's risk has decreased or increased by the fibrosis. So all these scores need a follow-up. Like I discussed, if it's a low risk, then you can definitely follow up in 1 year. But if it's a moderate to high risk, 3 to 6 monthly follow-up is needed because then only you will understand that which patient has changed from the higher to even the higher risk or they have become better with your treatment and you still need to be more aggressive with their management because we know that even in spite of the availability of so many medications, we still see high risk of cardiovascular deaths in our country and high risk of complications in spite of the SGLT2 being available for 10 years. Now with GLP-1 analogs also being available and with generics coming in, I think this is the right time. The risk scoring should be a routine part of our practice. And with AI coming in, I think this should be even more important because AI has helped us to not only manage the patients better because it gives you a baseline graph, it gives you a follow-up graph, it gives you how the trend will be. So these are the ways AI can be used judiciously in our practice. Not that I'm saying that for everything AI is going to be there, but these are the parameters or the things where AI can be of great help, I think.
Thank you very much, ma'am. And we have Dr. It is very important the message Dr. Pramila has given to us, and we should try to incorporate those things. Thank you, ma'am. We know that you have some other commitments also, and you have to go to the all these busy schedules and travel. Thank you again once more for your time, valuable time. Now, may I go to the Dr. Subhas. Dr. Subhas is there?
Yes, yes. Go ahead, Dr. Ashutosh. I'm here still.
Yeah, Dr. Subhas, we are missing you. So,
Me too.
Because imagine CardAppCon without you is something big gap, vacuum in the conference. But still, we appreciate that you have given the time, at least digitally. So, in your opinion, what should be our behavior in terms of looking at the so many GLP-1 which are there in the obesity practice? So, where do you see your topic as a relevant topic in terms of that, and what will be the 2-3 important key message you would like to give the audience?
See, we are going to use GLP-1 receptor analogs. We are going to use other molecule also coming up, dual or triple incretins. But how long we are going to use it, and how long we are going to maintain these issues with the molecule? So we have to build these molecule at the at the base of lifestyle and diet, exercise pattern. And to achieve that pattern, we need to understand that how do we make people understand how, that they should do these thing in their day-to-day living. How do we make them help them in terms of achieving those target of having a healthy behavior? So we need to grab these core issue of behavior changes which I have discussed, especially the motivational interviewing part, the trans-theoretical model of behavior change. This helps us to change patient's life in terms of your helping him in terms of changing different stages of behavior. So this is very important. Since we have not learned it in early days, this is a high time that we should pick up these techniques of patient help, because only with molecules, only with therapy, we cannot achieve the long-term goal. And why we need to have treatment in terms of obesity, and we change these behavior from beginning itself, so that the people, those who will not get obesity, we can have a preventive aspect before even we can use any molecule, if at all it is needed for them. So I request and I suggest that everyone should look at these parameters of behavior change and how do we help society in long run.
Thank you, Dr. Subhas, for your valuable insight. And now it's over to Nidhi for the next session.
Thank you.
Thank you.